Hi everyone. Thank you for joining our webinar. Today we have with us Dr. Atul Malhotra. He's a professor and research chief of pulmonary critical care and sleep medicine at the University of California, San Diego. Dr. Malhotra has extensive research experience in several NIH grants studying sleep apnea and has also been the past president of the American Thoracic Society. We're very grateful to have him today presenting on loop gain and sleep-related breathing disorders.
Thank you. Can you see that okay? And you can see my mouse?
Yes.
Great. So thank you so much for the invitation. Thank you for having me here today. We're going to talk today about a concept that's known as loop gain. I'll define what that means as I go along. I'd like to thank the American Academy of Sleep Medicine for the invitation. By way of disclosure, I was with the American Thoracic Society for some years. ResMed gave a philanthropic donation to UCSD. There's an academic industry partnership known as MedX Cloud, which is with academics and ResMed, but I take no personal income from either ResMed or MedX Cloud. I do have some industry disclosures related to medical education, including Jazz Pharmaceuticals, Zoll, Eli Lilly, and LivaNova. The vast majority of my funding comes from the National Institutes of Health. The objectives for today's talk, I'd like to be able to define loop gain by the end of the hour. I'd like to understand the influence of control of breathing on obstructive sleep apnea pathogenesis, and to appreciate the potential therapeutic approaches targeting loop gain in obstructive sleep apnea. So just to give that some context, I'd like to start by mentioning that obstructive sleep apnea affects up to 1 billion people worldwide. We did this paper in the Lancet Respiratory Medicine a few years ago now. With the apnea-hypopnea index greater than 5, it's almost 1 billion people worldwide with OSA based on our best estimates. If you think an AHI more than 5 is too liberal of a threshold, if you use a stricter threshold, more than 15, where there's really no debate, these people need treatment, it's almost 500 million people worldwide with obstructive sleep apnea. You might say, who cares? Why does it matter if they're people that have sleep apnea? If they're not coming to clinical fruition, maybe just leave them alone. So we did this study. Raphael Heinzer was the lead author, published in Lancet Respiratory Medicine, where we went into the community in Switzerland and did sleep studies on people and identified about 23% of women, about 50% of men had an AHI over 15 events per hour. I'll point out the obesity problem is much less in Switzerland than it is in the United States, but be that as it may, it was still about half of men, about a quarter of women had clinically important obstructive sleep apnea. Again, you might say, who cares? These are people in the community. Unless they come to clinic with a problem, just leave them alone. Well, in that context, the apnea-hypopnea index is predictive of hypertension, diabetes mellitus, and depression, all diseases we take quite seriously. So it's hard to say just ignore these people when they're afflicted with important conditions. We're not saying sleep apnea is necessarily causing all these things, but again, it's hard to ignore these people when they have important problems. So there's a concept that emerges here that sleep apnea is highly prevalent, but not all are likely to get cardiovascular benefit from CPAP. Why do I say that? Well, it seemed to be unlikely that 50% of men in Switzerland would have cardiovascular benefit from CPAP, because not all are at cardiovascular risk. Some will die of Alzheimer's or cancer. Some will die of heart disease for other causes. And so I think the heterogeneity of sleep apnea is the concept that emerges here. Not all sleep apnea is the same, and this heterogeneity is going to be the focus of today's talk. So take-home message so far is that sleep apnea affects up to 1 billion people worldwide. The numbers vary with the scoring criteria and the equipment used. We need to think about how to address this global burden of disease and move away from this one-size-fits-all approach. So why am I pessimistic about a one-size-fits-all approach? The SAVE study is published in New England Journal that many of us know. This is a CPAP for prevention of cardiovascular events and obstructive sleep apnea. It was a well-done study from Australia, India, and China. The bottom line here is that therapy of CPAP plus usual care, as compared with usual care, did not prevent cardiovascular events in moderate to severe sleep apnea in patients with established cardiovascular disease. And there are a variety of reasons for this finding. We could debate the nuances of why the study failed, but it's a consistent finding. And I think a well-done study, again, speaks to the idea that this one-size-fits-all approach is not really working for us. And to me, there are sort of at least 3 take-home messages from the study. Number one is we need better therapies and better adherence. They achieve the stated goal of at least 3 hours per night of CPAP adherence, but maybe that's not enough. We need to identify high-risk patients better. Again, this one-size-fits-all approach, which is giving people CPAP and hoping it helps, probably isn't working. And we need more basic research regarding mechanisms, which is perhaps a shameless plug for my lab. I don't want to be totally dismissive of CPAP, though, because I think CPAP is superb therapy for many patients. So this is something we published in Chest a few years ago. Y-axis here is cumulative percent of patients. X-axis here is time. Let's look first at the blue guys here. The blue guys are using usual care. About 70% are achieving Medicare criteria for CPAP adherence. That's pretty good. 70% adherence is better than most other chronic medical therapies, be it inhaler use in asthma, anticonvulsant use in epilepsy, etc. So this is drawn from almost 1 million patients, 137 million nights of recording. So we're able to propensity match the usual care group to another group that was using advanced technology, active patient engagement, where they had an app that would sort of give them a thumbs up if they're doing as well, helpful hints if they're doing poorly. And in that context, this is not randomized, but propensity matching, we saw about 87% adherence using this advanced technology or active patient engagement. Why am I emphasizing this? Well, 87% adherence is really quite good. A defeatist attitude about CPAP is really not justified because the vast majority of patients will do well with it. Now, you might argue not everybody's on this slide. You have to get a CPAP machine to get on this slide, and that's true. So if you have no access to healthcare, or you couldn't afford a sleep study, or you absolutely refused a machine and never got it, you'd never get onto this slide. We try to be as inclusive as possible. So if you're able to get a machine and plug it in and use it for 1 hour in total, then we included you on this slide. If you're in some area where they had no access to CPAP whatsoever, or no access to healthcare, you'd never get onto this slide. But for many of the patients we see, the slide does pertain, and 87% adherence is really quite good. And again, to reemphasize, a defeatist attitude about CPAP really is not justified. That sample size wasn't enough. We looked at 2.6 million patients and saw about 75% adherence in a subsequent study here, suggesting that CPAP is really pretty good for many patients. So CPAP is a treatment choice. For sleep apnea, improves symptoms, improves blood pressure, has transformative benefits for some patients. The defeatist attitude is not justified. But there's general acknowledgement that we need new therapies based on ongoing research, and that's what I'm going to emphasize today. There are likely to be multiple mechanistic pathways which can help in terms of individualizing therapy. Patients don't all get sleep apnea for the same reason, and they vary in their clinical expression. So I'd like to start with some semantic definitions. As a phenotype is expression of disease in terms of how it presents clinically. So an obese, older male with sleepiness might be the phenotype of obstructive sleep apnea syndrome. An endotype, in contrast, is a subtype of a condition which is defined by a distinct pathophysiological mechanism. So upper airway anatomy, or in today's case, we're going to talk about loop gain, control of breathing, would be an endotype or mechanism underlying sleep apnea. There's a concept which is emerging that the mechanism underlying sleep apnea might affect the clinical expression of disease. So anatomical sleep apnea might have different consequences than loop gain-driven sleep apnea or upper airway dilator muscle-driven sleep apnea. They all may be somewhat different, and that's an area of ongoing research. In terms of sleep apnea mechanisms, upper airway anatomy is an important factor, which Richard Schwab, others have worked on that area and done some important work. The pharyngeal dilator muscles are important. The genioglossus and other upper airway muscles control upper airway patency during sleep, and that's an important area. The arousal threshold or propensity to wake up is important. So if you have a low arousal threshold, you wake up easily. If you have a high arousal threshold, you can sleep through anything. The people with low arousal threshold don't accumulate respiratory stimuli or are unable to activate their pharyngeal dilator muscles, and they tend to have repetitive apnea. Today we're going to talk about loop gain, which is this engineering term to talk about control of breathing. I'll define that more in the next slide. And there are other factors as well, which are probably important mechanistically, which we won't get into today. So what is loop gain? It's an engineering term which defines the stability or instability on a feedback control system. So a system with a high loop gain is one that's prone to instability. The system with the low loop gain is one that's intrinsically stable. The analogy some people find helpful is the thermostat analogy, whereby we think about regulating room temperature. And by analogy, we can think about regulating CO2 in the body. So right now I'm sitting in a room that's about 20 degrees Celsius. And right now my PCO2 is sitting around 40 millimeters of mercury. So let's think about situations where temperature in the room might oscillate and go up and down. And that would be analogous to high loop gain or an unstable control system. So if temperature in the room is 20 degrees Celsius, the thermostat is way too sensitive. If the temperature goes to 19.99 degrees, if that's enough to turn on the furnace, we'll have a situation where temperature in the room tends to oscillate because the thermostat is just way too sensitive. And by analogy, if you had a chemosensor that was way too sensitive, if CO2 went from 40 to 39.99 degrees millimeters of mercury, and if that was enough to affect your control of breathing, you have oscillations in your control of breathing. Your CO2 would be all over the place, and you have an unstable control system or a high loop gain. What about situations where the furnace is too powerful? So let's say temperature in the room goes from 20 degrees to 19 degrees Celsius. If the furnace is too powerful and blasts heat all the way up to 80 degrees Celsius, you'd have a situation where the furnace is too powerful. Temperature in the room would be all over the place because the furnace is too powerful. You'd have an unstable control system. By analogy, if I'm asleep and my PCO2 goes from 40 to 45 when I go to sleep, if I wake up and my CO2 goes all the way down to 10 millimeters of mercury, it'd be too powerful of a system. My CO2 would be below my apnea threshold. I have a very unstable control system or a high loop gain or one that's prone to instability. And the other analogy that can be helpful is thinking about the size of the room. So if I'm sitting in a small room right now in my office, trying to oscillate the temperature of this room versus the Houston Astrodome, it's a lot easier in this room than the Astrodome because there's a lot more space, a lot more gas in the Astrodome. So in the room I'm sitting in for a given furnace and a given air conditioner and a given thermostat, it'd be easy to oscillate the temperature in this room versus the Astrodome. By analogy, the CO2 stores in the body, if you have a huge CO2 store, it's going to be hard to oscillate the value as compared to a much smaller store. That's something referred to as the plant. So the way to think about loop gain is with that thermostat analogy, situations that would lead to oscillations in room temperature by analogy would lead to oscillations in PCO2. A system that's prone to instability has a high loop gain. A system that's intrinsically stable has a low loop gain. The other way to think about it is systems that are prone to develop central apnea tend to have high loop gain, and situations where you're not prone to central apnea tend to have a lower loop gain. So I'd like to talk a little bit more about sleep apnea heterogeneity. Li Xuan Yi, who was with us in Boston. Prior to that, she was at University of Pennsylvania working with a group in Iceland. Talked about different clusters of sleep apnea. Identified 3 clusters. There's a disturbed sleep group that had some insomnia, about a third of sleep apnea patients. About 25% were minimally symptomatic or asymptomatic. There was a severe group that had severe sleepiness, about 43% of patients. The reason this was interesting is this severe group with sleepiness seems to be the group at cardiovascular risk. And so again, speaking to the idea that one size fits all approach is not going to work, many of these patients are not at cardiovascular risk. It's fewer than half of patients with sleep apnea seem to be at cardiovascular risk, again, suggesting we need to be smarter about identifying different phenotypes of disease. I'll talk more about the endotypes in a second. So this is a very busy slide deliberately, but I'd like to go through it carefully just to talk about why these endotypes matter. So these endotypes are mechanisms underlying sleep apnea, may be important. Why is that? These endotypes may guide therapeutic interventions. Oxygen or acetazolamide diamox may be helpful for patients with a high loop gain. If you have an unstable control system, you can give oxygen or acetazolamide to stabilize breathing. That can be quite helpful in some cases, as we'll talk more about. Uvulophalangoplasty may be helpful for the subset of sleep apnea patients who have anatomical compromise. at the level of the velopharynx. It might be that risk factors for sleep apnea may be related to endotype or mechanism. Patients with post-traumatic stress disorder may have a low arousal threshold. That may be why they're prone to having sleep apnea in many different studies. Upper airway dilator muscle dysfunction may be common in patients with neuromuscular disease. Sleep apnea endotypes may predict clinical phenotypes. So the mechanism might predict clinical expression. So, for example, sleep apnea in the elderly may have unique underlying mechanisms, which could explain why there are fewer complications. In several different studies, sleep apnea in the elderly has different complications than sleep apnea in younger people, and that may be related to underlying mechanism. And sleep apnea endotypes or mechanisms may predict treatment responses. So, for example, high loop gain or unstable control of breathing may develop central apnea when you put them on CPAP. We'll talk more about that. A low arousal threshold or propensity to wake up may develop insomnia when you put them on CPAP. Andrei Zinchuk at Yale and others have done nice work in that area. And the high loop gain or unstable control of breathing may predict surgical failures. If you're doing upper airway surgery for sleep apnea, that may not work if you don't address the underlying control of breathing abnormality. And there's several studies in that context. So let's talk more about loop gain or control of breathing, which was my mandate for today. Magda Yunus up in Winnipeg, Canada, did some nice work in this area, as did Michael Koo at University of Southern California. But one example clinically of a high loop gain is Cheyne-Stokes breathing. This is a form of central apnea. You see a thermistor and abdominal belt. The thermistor, there's a cessation of airflow without respiratory effort. There's a form of central apnea, in contrast to obstructive apnea, where you'd have ongoing respiratory effort to a cessation of airflow. This is central apnea without airflow, without respiratory effort. It's a crescendo-decrescendo pattern of breathing, whereby breathing speeds up and slows down. And there's a 6-minute time scale, so the cycle's about once every minute. And there are 3 things to point out in association with this breathing pattern. Every time they stop breathing, they desaturate. They stop breathing, they desaturate. And there's a time delay in this context because this patient has congestive heart failure. There's a circulatory delay, explains why there's a delayed desaturation. There's hypoxia with reoxygenation, which can lead to oxidative stress. The second thing to point out is in the EEG, there's a burst of alpha in the electroencephalogram. These patients wake up short of breath. And it turns out paroxysmal nocturnal dyspnea, one of the classic symptoms of congestive heart failure, is often related to this breathing pattern. This patient with a high loop gain or unstable control of breathing tends to wake up when they're breathing a lot, and that leads to paroxysmal nocturnal dyspnea. The third thing to point out in the electrocardiogram is a burst of tachycardia that's seen here. These patients have surges in catecholamines that are thought to be deleterious in congestive heart failure, and that's driven by this high loop gain or unstable control of breathing. So to summarize, this is a form of high loop gain, Cheyne-Stokes breathing, which is very common in congestive heart failure. It's characterized by cessations of airflow without respiratory effort, intermittent hypoxemia with reoxygenation leading to oxidative stress, recurrent arousals from sleep leading to sleep fragmentation, and paroxysmal nocturnal dyspnea, and bursts of catecholamines thought to be deleterious in congestive heart failure. This is a high loop gain or unstable control of breathing, very common in congestive heart failure. We're doing some work as well in Mozambique. This is just published in the Journal of Clinical Sleep Medicine. Irina Mbanzi is a cardiologist in Maputo, Mozambique, that's been working with us in this context and seeing these sort of breathing patterns, even in teenagers and young adults with heart failure in Africa. We're seeing this sort of breathing pattern. So there's different ways of quantifying the loop gain. The details don't matter for today's conversation. On the x-axis here is the loop gain quantified as a measure of the instability and control of breathing. On the y-axis here is the apnea-hypopnea index. You can see the values are all over the shop. Loop gain is a poor predictor of the severity of sleep apnea if you just take all comers. However, Andrew Wellman and I published this some years ago now, looking at a subset of patients that we predefined based on the mechanics of the airway. If you have a very, very sturdy airway, control of breathing doesn't matter because you're anatomically protected. If you have a very, very floppy airway, control of breathing doesn't matter because you're mechanically predisposed and the control of breathing is less relevant. If you're in between, so-called atmospheric peak rate and intermediate anatomy, Then it gets more interesting. So that group we pre-specified, that's sort of anatomically intermediate, not protected, not severely predisposed, but in between. If you put loop gain on the x-axis and the apnea-hypopnea index on the y-axis, you have a very robust correlation between the two, suggesting that control of breathing may be very important for a subset of obstructive sleep apnea patients. Why do we care? Well, we can manipulate loop gain based on various interventions, as I mentioned. So Brad Edwards, others have worked on this with us. Oxygen is a way to stabilize control of breathing or lower loop gain. Acetazolamide or Diamox is a way to do that as well. Loop gain can be manipulated pharmacologically in a subset of sleep apnea patients. Also, the idea that combining interventions may be helpful for sleep apnea, as Brad and others have shown. I'll show you some more recent data in a second. So Chris Schmickel in my lab here has published on acetazolamide. During the pandemic, our lab was closed, and so we had to do systematic reviews and things because that's all we were able to do. If you look at obstructive sleep apnea shown here, central sleep apnea with heart failure shown here, central sleep apnea with high altitude shown here, idiopathic central apnea shown here. This is a forest plot. Here's the line 0, standardized beat difference shown here. Very consistently with acetazolamide seems to help all of the above in terms of all these different forms of obstructive or central apnea. There's some improvement with acetazolamide. Some people argue it's not that well tolerated. In general, it is. We published actually on the side effects as well. Side effects tend to be dose dependent and self-limited. Acetazolamide does seem to be well tolerated, at least in general, and may be helpful, at least in some patients with obstructive sleep apnea. In some cases, quite marked improvements seen using this agent to lower loop gain or to improve control of breathing. So Scotty Sands, who's now independent, but was in my lab in Boston when I was there, has done different techniques to try and quantify loop gain using sophisticated analyses or signal processing of the polysomnographic data. Phil Terrell was the first author in this paper we posted in the European Respiratory Journal. It looks at the ventilatory response to spontaneous apnea. That's a measure of the gain on the system, of the loop gain. Tested this in mathematical models and compared to gold standard measurements, which we'll talk more about later. Seems to be directionally accurate when we look at response to oxygen or acetazolamide, both of which would be predicted to lower loop gain. And there's the possibility of getting a loop gain off a polysomnogram. Scotty has developed this much further since this original work, and now we're able to quantify that metric using standard polysomnography. It used to be the case where we required an MD or PhD to be awake all night to gather the data, and became quite cumbersome. But we're now working on doing this in a high throughput way to automate things, and this is the work of Scotty Sands and others. So Shamim Namadi is also my lab looking at model characterization of ventilatory stability using spontaneous breathing. This was published in the Journal of Applied Physiology some years ago. The mathematics is quite complex, but suffice it to say, looking at spontaneous fluctuations in tidal volume, carbon dioxide, and oxygen, a so-called trivariate model, was used to derive parameters in this autoregressive modeling. Mathematics was complex, but suffice it to say, engineers and others can use sophisticated analyses to try and draw a loop gain from existing data. It doesn't require complicated experiments, but you can get it at the values clinically. But Jeremy Orr in my lab in San Diego has also done work in this area, just trying to get it from a home sleep test. So we're doing fewer polysomnographies these days and more home sleep tests. Is that enough? And so Jeremy published this in the American Journal of Respiratory Critical Care Medicine a few years ago, measuring loop gain via a home sleep test. He looked at the ventilatory response over spontaneous disturbances, trying to make these endotypic assessments more accessible to clinicians. Ideally, we'll know why a patient has sleep apnea, what's the risk of a particular complication, what to do about it. So I can be in clinic now, seeing a patient, and have a pretty good sense of what their loop gain is based on these sorts of approaches. And the ones who are prone to instability or unstable control of breathing may be those patients most amenable to interventions, such as oxygen or acetazolamide. I also know that those ones with unstable control of breathing may be most likely to fail. For example, upper airway surgery, which is not addressing a control of breathing problem. More recently, we published this in the British Medical the BMC Pulmonary Medicine in 2022, Chris Schmickel, who I mentioned earlier, did a retrospective cohort study based on polysomnography. It's from over 1,000 patients. A third had a high loop gain. And the final model had a higher apnea-hypopnea index, a lower hypopnea percentage, hypopneas versus apneas, to predict a higher loop gain. The values here in terms of the correlations are sort of modest. You can R of 0.48 and a discriminating high versus low loop gain area into the curve of 0.73. So it's okay, but not great. But suffice to say, they're data that are clinically accessible, which we can get off a sleep study. And to our knowledge, is the first prediction model of loop gain based on readily available clinical data, which may facilitate retrospective analyses of existing data sets or better patient selection for clinical trials, eventually for clinical practice. So Mike Stankina is in Rhode Island now, but he was in my lab prior to that in Boston. We're looking at the clinical use of loop gain or unstable control of breathing measures to determine CPAP efficacy in patients with complex sleep apnea. So complex sleep apnea is a bit of a controversial entity. But there are some people who put on CPAP and they get central apneas. And the feeling is those are patients with a high loop gain or unstable control of breathing. We looked at 32 patients with complex sleep apnea and 17 full data sets. We looked at something they call the duty ratio, which is a way of measuring or estimating the loop gain. The loop gain was higher for patients with complex sleep apnea whom central apneas persisted after 1 month of the CPAP therapy. Loop gain measurements may enable a priori determination of those who need alternative modes of positive airway pressure. Let me explain more what I'm talking about here. This is from the same paper. Look at the loop gain on the x-axis and the apnea-hypopnea index in the y-axis here. There's some of these so-called non-responders that have residual apnea-hypopnea index, and these are patients in general with a high loop gain compared to those who stabilize control the breathing. Why does this matter? Well, this parameter of control of breathing that we can estimate clinically may predict who has persistent central apneas on CPAP. If we can identify those people a priori, we can intervene early, perhaps, and give them a better result rather than having them struggle with persistent apneas with an incomplete result. I mentioned earlier the ability to predict surgical responses if you're getting upper airway surgery. So Bob Owens in my lab here is now independent in San Diego. Did some analyses on physiology-based modeling. We looked at the effect of upper airway surgery on loop gain. And the bottom line is high loop gain or unstable control of breathing was predictive of surgical failure. If you do a uvulopalatopharyngoplasty on somebody, they have residual disease, you haven't addressed their control of breathing problem. And it might be that a high loop gain predicts surgical failure, and those are maybe patients we shouldn't operate on, or prepare for additional interventions that may be required to lower the loop gain afterwards. The idea here is if we can stack the deck in our favor and identify the home runs and strikeouts ahead of time, maybe we can identify the patients really likely to benefit or those very likely to fail and act accordingly. The loop gain does lower after surgery, suggesting it's at least a partially acquired abnormality. It turns out low arousal threshold or propensity to wake up also predicts surgical failure. Perhaps that's a therapeutic target, maybe giving a sedative hypnotic that raises the arousal threshold may be helpful here. And Eric Kazarian is a surgeon who's now at UCLA, just got an R01 funded from the NIH to study this more rigorously. I did want to come back to the concept of complex apnea, which I mentioned earlier. This is from a big data analysis looking at trajectories of emergent central apnea during CPAP therapy. I'll point out I was pretty skeptical of the area of complex apnea. I thought these were just patients who had air leaks or other problems that resolved spontaneously, and I was not too concerned about it. We did a big data analysis here on 133,000 patients who used CPAP for 90 days, had more than 1 day, more than 1 hour of use in weeks 1 and week 13. There was a proportion of patients with central sleep apnea in week 1 or week 13 was 3.5%. Of these, central apnea was transient, persistent, or emergent in 55, 25, and 20%. So there's a small subset, 3.5%. You need these huge sample sizes to see the numbers. It's transient in 55%, persistent in 25%, and emergent in 20%. Essential apnea patients tend to be older, higher residual apnea-hypopnea index, essential apnea index at week 13, and more leaks. Patients with any treatment-emergent central apnea are higher risk of therapy termination versus those that did not. As I point out, we think these ones that have persistent central apneas are those with high loop gain or unstable control of breathing. You might say, what do we do about it? Well, we published this paper in the journal Clinical Sleep Medicine. Again, it was an observational study, not a randomized trial, using big data. Look at adherence to positive airway pressure after switching from CPAP to ASV. Adaptive or auto-servo ventilation has been developed for heart failure. There's some emerging data on that, which we'll talk about another day. But suffice it to say, occasionally for central apnea or complex apnea, we'll switch patients from CPAP to ASV, and the question is what happens. The bottom line here is you look at trajectories of positive airway pressure usage. You can see declining use here. The patients are switched. Here, abruptly, you can see improvements in positive airway pressure usage, and concomitantly, you can see improvements in residual apnea-hypopnea index at the time of the switch. So you see this declining PAP usage and abrupt improvement at the switch, and persistent improvements in adherence after the switch with concomitant improvements in residual apnea-hypopnea index. Again, it's not a randomized trial, so we don't know why they were switched, and we don't have a control group here. It looks like the declining CPAP use would eventually lead to therapy discontinuation, which would be our prediction. But it might be the case in these patients with persistent or emergent central apneas that switching them to an ASV type device might be helpful because it leads to persistent improvements in adherence that look to be sustained over a couple of months with concomitant improvements in residual apnea-hypopnea index. And so this is the concept of loop gain being applied clinically, where these patients who have high loop gain or unstable control of breathing get poor results with CPAP, may be rescued by ASV, at least in some cases. So I have one or two summary slides that should hopefully wrap things up nicely. If you look at treatment of obstructive sleep apnea, nasal CPAP is the treatment of choice, as I mentioned. It has transformative benefits for some patients, and a defeatist attitude about CPAP is really not justified. There are a variety of other possible treatments that might depend on the underlying mechanism of disease. For today, we've focused on control of breathing or respiratory instability, or high loop gain, unstable control of breathing. In those cases, oxygen or acetazolamide, Diamox, may be helpful as a potential treatment for the subset of patients who maybe don't tolerate CPAP or who have issues with CPAP, such as treatment emergent centrals. And so this is the idea that we can look at the underlying mechanism of disease, pick the therapeutic intervention accordingly, and come up with a personalized medicine approach to treating obstructive sleep apnea. This is my final slide. I'll summarize by saying, in terms of loop gain, it's an important concept in control of breathing. It's likely important in central sleep apnea and Cheyne-Stokes breathing, as I showed you, and probably in a subset of sleep apnea patients, as I showed you. Those patients with intermediate anatomical predisposition may be particularly susceptible to instability and control of breathing. The reason it matters is that it's actionable. You can use oxygen or acetazolamide or ASV, adaptive or auto-servo ventilation, as a way to stabilize control of breathing, and may be quite helpful for a subset of obstructive sleep apnea patients. And it may be an important component of personalized therapy. Treating the underlying cause of sleep apnea may be a viable approach for patients who don't do well with CPAP. I'd like to stop there. I'd like to thank you all for your attention. It's been my pleasure to be here today. Be happy to take any questions.
Hi, Dr. Malhotra. That was a wonderful talk. I have a quick question. So, you have this, you publish this predictive model that you can potentially anticipate patients who have high loop gain. Would you consider then, when we're doing our in-lab titration studies, potentially if we can validate this in certain patient populations, then maybe just switching over to ASV earlier, or maybe considering, because sometimes we end up getting these treatment emergence central events, and I'm just trying to potentially prevent this.
Yeah, I think it's a good idea. It's a good concept. I'm a big believer in randomized trials showing improved outcomes before we sort of adapt these things. So as you point out, we need further validation, but I think a good study to do might be to identify patients likely to develop treatment emergent centrals or complex apnea, and then randomize those high-risk patients to either usual care with CPAP or ASV. And if you showed improvements in outcome in that context, I think that would be a great kind of viable approach to using applied physiology at the bedside. I don't have the data yet. Like, we can sort of retrospectively identify who were the high-risk patients and identify them kind of a priori, but we haven't randomized patients up front to get an early intervention like that. A lot of people get ASV, I think, unnecessarily, so I'm not pushing that per se, but I think there is a subset that we can define a priori that's likely to do well. So I think you're right on the money with the question.
There is a question in the chat that asks, how was the loop gain measured in the study?
Yeah, so there are a variety of different loop gain measurements. I went through quite a few studies, and so the answer is it depends. The technique developed by Magdi Yunus that I mentioned in 2001, talking about chemical control of breathing in the American Journal of Respiratory Critical Care Medicine 2001, used a technique called proportional assist ventilation, or PAV. And that was a way of promoting unstable control of breathing. You amplify the gain on the system and see how much amplification it takes to destabilize control of breathing. Subsequently, we've done other techniques with pressure drops that Andrew Wellman helped to develop in my lab, and Scotty Sands developed the techniques with signal processing and polysomnography. So a variety of different ways of measuring it. It actually gets pretty nuanced because there's different types of loop gain, there's dynamic and this and that. So I don't want to get into that sort of degree of detail today, but there are a variety of ways of measuring it.
And the next question asks, could you talk through how oxygen and acetazolamide reduce loop gain?
Sure. So one way to think about hypoxia increasing loop gain is you think about high altitude periodic breathing, where people develop this sort of not Cheyne-Stokes type pattern, but a high altitude periodic breathing type pattern with alveolar hypoxia. And it stimulates chemosensitivity, and you get this unstable control of breathing because you've increased the gain in the system through hypoxia. So if you give people oxygen, that will reduce the hypoxic drive, and reducing the drive will stabilize the control system. Going back to the thermostat analogy, it reduce the fluctuations in room temperature by treating hypoxia, because there's less gain on the system or less hypoxic drive. With acetazolamide or Diamox, it's a carbonic anhydrase inhibitor that induces a proximal relative acidosis and drops the bicarbonate. It does stimulate breathing to some extent. The main effect appears to be a drop in the venous carbon dioxide tension, so the ability to excrete CO2 at the lung is impacted. So if you lower the CO2 in the venous system, there's less ability to excrete CO2, and that stabilizes control of breathing. The so-called plant gain is reduced by reducing that venous CO2 tension. Stated another way, if somebody had Cheyne-Stokes with heart failure, gave acetazolamide or Diamox, they have less Cheyne-Stokes because you've stabilized control of breathing.
And are there agents other than oxygen or acetazolamide that affect loop gain?
Yeah, the way to think about it is anything that would stabilize control of breathing would lower loop gain. Anything would make control of breathing worse or more unstable would raise your loop gain. So, for example, if somebody has congestive heart failure with pulmonary edema and you gave them Lasix or furosemide, and you dried out the lung, that would stabilize control of breathing or lower your loop gain, and your Cheyne-Stokes might go away. The reason for that is extravascular lung water can drive control of breathing. High left atrial pressure can drive control of breathing. Those things can contribute to hypoxia, which can stimulate control of breathing. So the way I think about it is anything that would promote Cheyne-Stokes or central apneas like that would raise loop gain or make things worse. And any drug that improves congestive heart failure would therefore logically lower loop gain.
And another question, could you please elaborate more about oxygen therapy for patients with high loop gain? Any specific indications?
Yeah, so again, I'm a big believer in randomized controlled trials. So what I'm showing you here is sort of physiological studies. And so sometimes I give talks and people start giving these treatments based on my talks. And, I want 2 phase 3 randomized controlled trials before I'll change standard of care. So should you give oxygen for obstructive sleep apnea? As of right now, the answer is no. But if we had 2 phase 3 randomized trials showing improved outcomes with that approach, that'd be great. We need to see improvements in blood pressure and sleepiness and symptoms and all that. Scotty Sands and I and others had a paper in the European Respiratory Journal a few years ago looking at oxygen as a treatment for obstructive sleep apnea. Interestingly, just the loop gain in isolation was not a very good predictor of oxygen response. And the reason is the complexity of this. There's lots of different pathophysiological traits that all interact with one another. So the idea that you can just measure one parameter and predict who's going to respond to oxygen, probably not. There was a study that was funded to look at giving oxygen to heart failure patients that involved Shirok Chabahari and Susan Redline and others, but that got terminated because of the pandemic and stuff. So the answer there is we don't know. So if you ask me as of today, should we give oxygen to treat obstructive sleep apnea? I'd say no, but it's an area of ongoing research. There may be subsets of patients who do well with efforts to lower loop gain by giving oxygen. But there's cost implications, there's risk benefit discussions, and again, we need hard outcome data before we can advocate for that.
In the POC study by Dr. Schmickel, there was prediction of LG based on proportion of apneas versus hypopneas in the total AHI. How did this correlate with patient symptoms or phenotype?
That study was done from sort of over 1,000 polysomnograms from a cohort that's there. We don't have sort of granular information on some of those parameters. So some things you'd like to know about symptoms, it's based on sort of this retrospective review. We really don't know. We have other data, some that are in peer review right now, suggesting these high loop gain patients may be the ones that are at cardiovascular risk. So for example, we looked at one of the randomized trials that's already been published, comparing CPAP therapy with oxygen therapy. And the ones who got the biggest bang for the buck in terms of CPAP therapy seem to be the ones with the highest loop gain. So it does seem to predict some of the clinical responses and some of the phenotypic responses that are of interest. But in terms of symptomatic improvements or individual symptoms and stuff, the answer is I don't know.
Thank you. If anyone else has questions, they can either speak up or put them in the chat.
I can elaborate a little bit on that last point, and that is that the patients with high loop gain seem to have high chemosensitivity or chemoresponsiveness. And in some physiological approaches, that corresponds well with some pathoexcitations. If you give intermittent hypoxia to increase chemoresponsiveness, you also increase some pathoexcitation. And so our prediction was the patients with the highest loop gain, if you give them CPAP, those may be the biggest blood pressure improvements compared to patients with low loop gain. So it may be a way of identifying patients most likely to benefit from intervention, understanding that the underlying physiology of those high loop gain patients is complex, but robust chemoresponsiveness may also predict robust sympathoexcitation. They may be the most amenable to CPAP intervention.
All right. If there's no other questions, I guess we'll end here. Thank you, Dr. Malhotra, for that excellent talk. Next month's webinar will have Dr. Meena Khan presenting on neuromodulation for sleep disordered breathing.
Great, thank you. Thanks for having me. Sorry about my voice.